for a very interesting and important topic, seeing beneath the surface, reading the MRI. Surgeons are all familiar with the CT many times, but the MRI is still a bugbear. I'm over to Dr. AMOL GAUTAM to make us all wise.
Yes, I mean, good morning all. At the outset, I would like to thank Dr. Samrat, Dr. Pankaj, and the entire surgical team for having us here. Actually, I am not the one radiologist. I mean, we are actually now 5 people will be speaking throughout the day. So I'm helping you to understand the MR imaging anatomy better and how the MR will help you in your clinical practice. Okay. So now let us go to this thing. And what generally we say that patient will identify the external opening. The surgeons will identify the internal opening. But the deeper ramifications and the deep-seated pockets will be actually, you need some imaging investigation, either an anal ultrasound or an MR. But I am the big advocate of MR because MR will be able to give us the anatomical details better than the ultrasound. And so actually MR is the modality of choice as far as the complex fistula in NO. Okay, now this, we all are familiar with the anal sphincter, and we have actually seen the first 3 speakers speaking about the surgical anatomy, the cadaveric anatomy. So now I will go straight to the anatomy on the MR. Okay. So now what are the advantages of MR over ultrasound or unconventional fistulogram, which we used to do before? Okay. So MR has got a multiplanar capability. Okay, we are actually using different sequences in multiple planes. Okay, so thereby identifying the sphincter complex better, thereby identifying the fascia and the deep spaces better. Okay, it is not operator dependent. It is actually especially for the ultrasound. We can actually do the transperineal ultrasound, or you can do an endoanal ultrasound. But again, it becomes an specific to the operator, the person who is doing, and it is very cumbersome for the patient. As sir said, it is very difficult when you do even a PR examination. So imagine the plight of a patient when you put the probe in the anal canal and how painful it will be. Okay, so just for the diagnostic purpose, we don't want to suffer the patient much. Okay, so on MR, we will have a better anatomical delineation of sphincter complex and deeper spaces because we have got a different sequences to identify. And the sphincter complex, the external sphincters are actually a skeletal muscle. The internal sphincters are actually a continuation of the smooth muscle, the circular muscle of the rectum. Okay, so thereby they are having slightly different signal intensities on MR. And as the fat is the major content of the perianal or the ischioanal or the ischiorectal fossae, so you will have a fat as a different signal. So it is very easy for us to identify these different spaces. And as we already say that the cross-sectional imaging, whether it is the CT or MR, is actually a boon for the mankind because we can see through what our naked eyes or what a surgeon or a clinician cannot see. So this is actually, for us also, we are trying to help you in identifying the complex anatomy over there. See, the deeper extent, ramification, abscess, and the levator ana involvement will be seen better with the MR. Okay, and it is actually proven beyond doubt in last 20 years that when you do the US surgery without preoperative MR, okay, and if you are not able to identify the deeper spaces correctly, you will likely to fail and patient will have a recurrence and the patient will come back to you. So it is always better to have a preoperative mapping of fistula on MR. Okay, so what is the MR protocol we use actually? So it is very important actually to acquire the good quality images. So for that, the technology's role is very important. So what we have to take actually the images parallel to the anal canal for the coronal plane and exactly perpendicular to the plane of the anal canal for the axial images. So these are not two coronal or axial images, but they are oblique coronal and oblique axial images. Okay, so what we have to do, we have to use a phased array pelvic coil. Previously, we used to do actually with the endoanal coil also. But that was again very cumbersome and very difficult for the patient, very painful. So actually, now the phased array coil, especially on 3 Tesla MR, we will have a very good resolution. So what we do generally, basically, we actually take T1 weighted and T2 weighted sequences with fat sat, and sometimes we use actually contrast to delineate the fistula better. Okay. Now, how to identify these sequences? Okay, now this is basically a T1 sequence where you can actually see this is the bladder, and the bladder is actually black on T1 weighted sequence. This is the T2 weighted sequence where the urine in the bladder is actually bright. Okay, the stir, can you see now the abundance of fat over here? The fat over here is abundance. This fat is getting suppressed on stir images, and can you see now the vessels over here? So vessels are actually showing a bright signal over here. So these are all post-contrast sequences. So this is how you identify the sequences on MR. This is why I was talking about how to take the planes. Okay, so this is actually the axial sequence, which is parallel to the perpendicular to the plane of the anal canal, and this is the coronal, which is parallel to the plane of the anal canal. Okay, now, so just identify this now. This is the coronal plane where actually see the levator ani muscle. Okay, the levator ani muscle has got the three components. The levator ani, they were over there, then superficial, and then the subcutaneous plane. Okay, so it is actually slightly darker on T2. We have an inner, the circular muscle which is continuing. On fat sequences, it will appear slightly brighter as compared to the skeletal muscle. Okay. So now the anatomy is better with this thing. I just wanted to use the laser pointer. Laser pointer.
लेजर पॉइंटर का
इतले करून देतात. ठीक है. Because that pointer was actually getting, so here I just wanted to show you how the anatomy in male and in female patient differs on the axial images. So you can actually see this is the internal sphincter, this is the external sphincter over here, this is the anal canal, okay? This is the intersphincteric plane where actually there is a slight amount of fat over there between the two planes, and this is the ischioanal fossa, okay? As compared, can you see in females? In females, actually, you'll see the okay. So in females, actually, you see the urethra, the vagina over here, the anal canal here, the intersphincteric space. Sorry. Okay. The pubo-rectalis muscle actually starts from the pubic symphysis and actually forms a sling around that. Again, can you see the very dark signal around the entire structures in the anogenital space? Okay, this is exactly the clock position. What you see clinically, we also see on MR. This is the anterior, this is the posterior or the natal left, this is the right, and this is the left, okay? And the anal canal, the clock position is exactly the same as what you see on your examination pattern. No, these are all anogenital spaces we have actually seen in the morning in the discussion, okay? So we'll see how they are, looks like on MR, okay? So this is the circular muscle, which is continuing downward as the internal sphincter. This is the external sphincter, the upper component, the superficial component, and subcutaneous component, okay? And in that, actually, you see the internal sphincter over here. So these are all three spaces. So actually, the supralevator space is over here, the high sphincteric space over here, and the low intersphincteric space over here. So can you just see on MR, actually, these are all very well delineated on the sagittal images. Okay, now we can see actually this is the fascia, this is the transverse septum fascia, which is called as Milligan fascia, and this is actually ischioanal fascia, which divides this space into the perianal space, the ischioanal space, and the infralevator space. Okay, this actually, we have seen these cadaveric images before. Okay, so this is how we actually identify the anatomy on MR. Okay, we'll just go back and see once again on the other sequences. I just wanted to reiterate here that this is actually something new for us also. It is something called as deep post-anal space, which is, located in the 6 o'clock position in the higher up in the anal canal. Okay, now we'll see the anatomy on the coronal MR. This is a coronal pituitary image. Okay, so these are the two fascias which we saw. This is the transversus perineal fascia, and this is the ischioanal fascia. Okay, and yeah, so this one. So now we see this is the perianal space. This is the ischioanal space. This is the infralevator space, and can you now imagine that there is nothing called as ischiorectal space, because whatever we see below the level is actually the anal canal. So there is a difference between the surgical anatomy and the anatomical anatomy of the anal canal. And this is the supralevator space above. Okay, so this is actually a deep perineal space in a male patient. Deep perineal space. And this one is actually superficial perineal space. Okay. Okay, so not all is actually what we see on MR is actually fistula in ano in all suspected patients. So we have to keep in mind about the differential diagnosis in certain cases. Here, in this particular case, actually we can see the only the wall thickening of the rectum and the anal canal. It is actually a case of proctitis, and there is no fistula in ano here. Okay. Another case where we actually see the some amount of collection at the coccygeal tip and no communication with the sphincter complex here. So this is actually a pylonadal sinus. So MR will actually help you not only to identify the fistula and ano and complexity, but also to see whether there are any differential diagnoses which are suspected to be the fistula and ano cases. So I think I will be able to, and these cases and these anatomy will get repeated over a period of over the day to help you understand the better. Thank you.
That's a beautiful introduction, sir. And I feel a practicing surgeon should walk into the radiologist room and look at the pictures in the console and get clarified. Because the pictures, what we see, films is only representative. They don't give the full picture.
Yes.
So it's always, you befriend your radiologist and pathologist. You walk to the room, have a cup of tea, discuss the case, what you are interested. We become wiser always, which I always do with my radiologist. Yes. They are one of the best of friends we should have. You should not fight with 3-4 people. One is your OT nurse, second is your anesthetist, third is radiologist, fourth is pathologist. You can afford to fight with your spouse. These 4 you should always befriend for better outcomes.
Yes.
Thank you, sir.
Thank you.